Okay, the point well taken. Dr. Malika with post-intravitreal injection endophthalmitis.
Yeah. Good evening. I'd like to thank the AO and AIOS for this opportunity. So I'll be speaking about our experience with post-intravitreal injection endophthalmitis, or PIE, no financial disclosures. So this is a retrospective analysis of all patients treated for post-injection endophthalmitis. And the only drug which has really caused endophthalmitis has been Avastin, and lately 3 patients post-IVTA. Even though we have been using all the drugs on-label and off-label, even for immunosuppressed patients, we have been using ganciclovir and clindamycin for scarnet. But these are the only, Avastin has been the drug which has caused all infections. And this could result from compounding or multiple punctures, but in our case, there was a cluster which was from a contaminated batch of the original drug, which was also causing infections elsewhere. So these were 14 eyes. I'll be discussing once in the beginning the cluster of infections, and then subsequently the sporadic cases and how to manage. So we had 14 eyes with the cluster Aspergillus endophthalmitis, 7 of which were diabetic, but this did not alter their management or outcome, the presence of diabetes. Most of these patients with fungal endophthalmitis presented at 2 or 3 weeks after the injection, 1 at 1 month and 1 at 3 months post-injection. So this is a delayed onset of symptoms. Once the symptoms started, there was a rapid onset of pain, redness, and vision drop in all these patients, and they all had severe anterior chamber and posterior inflammation at the time of presentation with balls of vitreous exudates. Initially, all patients underwent core vitrectomy because we were not aware of the fungal etiology. At 2 weeks, these vitreous isolates showed a florid growth of aspergillus, which was maximally sensitive to voriconazole and less to amphotericin B. So at 2 weeks post-vitrectomy, we treated all eyes with a follow-up injection of voriconazole and amphotericin B, and all patients were placed on oral voriconazole for 8 weeks. The eyes remained quiet for about 8 weeks after the core vitrectomy, though we could see balls of exudates in the inferior vitreous. And at about 8 weeks post-vitrectomy, there was a rapid reactivation of severe inflammation in all eyes. And at this time, they all had severe vitreous exudates along with macular hypopyon. A microbiologist advised that these exudates contain viable fungal organisms that are not adequately destroyed by the subsequent use of fungistatic agents that are available to us and need complete surgical removal at the time of second surgery. Which meant that we had to induce PVD, remove the posterior hyaloid, and then aspirate the premacular exudates and remove all exudates down to the retina. So here we are trying to access the macular exudates but cannot because of the posterior hyaloid. So a vitrector is put in and active suction is used to strip off the posterior hyaloid. And it is only after removing this that we are able to access the macular exudates with a soft tip cannula and remove these. In cases where PVD could not be induced over the optic disc, the subhyaloid space was accessed by doing a peripheral vitrectomy and then working posteriorly. All exudate balls were removed down to the retinal surface, and this is relatively safe within smaller gauge instruments. Any suspected retinal breaks were treated with laser. Following this complete vitrectomy, we treated each eye with injections of amphotericin B with voriconazole at gradually increasing intervals for a total of 10 months. And over 6 months, we found that the vitreous started turning clear in all treated eyes. So this was a very intensive treatment, as you can see this. And one patient developed hypersensitivity to intravitreal amphotericin B, which manifested as increasing AC inflammation following each injection. And at 3 years, most of these eyes we have been able to salvage some vision, and the mean vision is about 20 by 400. 12 of 14 eyes have severe hypotony. 10 of 14 eyes have extensive epimacular membranes and macular scars. All phakic eyes have developed cataract, and posterior synechiae A, which led to a pupillary block glaucoma in one patient requiring an emergency cataract surgery. Cataract surgery has been associated with posterior dislocation of the lens in one eye and posterior dislocation of the nuclear fragments in another eye, and this we believe is because of the zonular compromise from the multiple vitreous interventions in the preceding year. 2 eyes of both of diabetic patients developed neovascular glaucoma 3 months after they underwent cataract surgery. So this requires vigilance and a high index of suspicion, because this can also be salvaged and was done in one of these eyes. So we believe that the treatment for this particular cluster was extremely aggressive and prolonged because of the high aspergillus load that was inoculated in a contaminated vial. And we believe that endophthalmitis caused by contaminated drug is more destructive and severe than the sporadic infections that we generally see caused by breach in procedure, because that has a smaller organism load. As you will see from this subsequent series, which was a sporadic infections, likely bacterial, most of them were culture positive or presumed bacterial. So these were 9 eyes, of which only 1 was diabetic. So diabetes was not a predisposing factor for the infection. Now these patients, they all presented within the first 3 days of the infection with floaters, painless, rapid vision drop in 8 of 9 eyes. Pain and redness was only in 1 eye. The presenting visual acuity was very poor, light perception to 20/400 only, and 8 of 9 eyes presented with quite white eyes, white conjunctiva, relatively quiet anterior chamber, but significant vitreous haze and exudates. And we believe that this difference in the post-injection endophthalmitis compared to a post-cataract surgery endophthalmitis is because in the intravitreal injections, the organisms are introduced into the vitreous, causing an initial quiet vitreitis with vitreous exudates, whereas during cataract surgery, the site of inoculation is the anterior chamber, causing a very symptomatic iritis with pain and congestion. 4 of these patients were culture positive, and the 1 patient with streptococcus infection had upper respiratory tract infection on the day of injection, and this is known to increase the upper respiratory commensals on the ocular surface. So we believe that we should avoid injections when a patient has upper respiratory infections. Now, TAP with intravitreal injection was effective only in 2 cases, and all the other cases required a subsequent vitrectomy, and in fact, it was required twice in the diabetic who developed a streptococcus infection. There was a good prognosis, good outcome in these bacterial cases. 8 of 9 eyes recovered baseline visual acuity. Only 1 eye that was a diabetic and had streptococcus had a poor outcome. An interesting thing we noted was that because of the inflammation of infection and removal of the anti-VEGF during the vitrectomy, there was worsening of the primary macular problem at the end of infection resolution. So from the second case onwards, we also started injecting an anti-VEGF along with the antimicrobials at the end of the vitrectomy, so that at the end of management of the endophthalmitis, there was a good macular status, as you can see here. And lately, we've had 3 patients of post-triamcinolone acetonide injection endoph, and these were very similar to the sporadic Avastin endophthalmitis in terms of having a white conjunctiva with dense vitreous exudates, as you can see in these surgical video grabs. The only difference from post-Avastin infection was the presentation was very delayed, 1 at 1 month, 1 at 4 months post-IVTA, and 1 at 5 months post-IVTA. And this, we believe, is because the steroid suppresses the inflammation as long as it is in the eye, and hence the delayed presentation. They also did well, and 2 of 3 eyes recovered baseline visual acuity, and 2 of these required vitrectomy. IOAB, just TAP and injection was not adequate. Thank you.